So for Spectrum International, it's wonderful to have uh, um, good, no, excellent speakers to collaborate with us. In this case, we have Professor Caroline. Professor Caroline serves as an associate professor at the Pacific University College of Optometry in Forest Grove, Oregon. He is a fellow member and diplomat of the Cornea Contact Lens section of the American Academy of Optometry and co-curator of the Contact Lens Museum. For the past 30 years, Patrick has served as a contributing editor for the Contact Lens Spectrum. He has published over 360 papers and authored 124 scientific posters and has lectured extensively throughout the world. So it is a pleasure to have you here, Professor Caroline. Please
Thank you.
go ahead. The floor is yours.
Well, welcome everyone to my office here at Pacific University. I'm so excited to be with you here today to share with you some new insights into scleral contact lenses. I think you're going to enjoy this next hour or so, and we're going to kind of begin in a strange fashion, and that is how it all started. The story of contact lenses started in Zurich, Switzerland, of all places, in 1887. And the original lenses that were produced at that time were obviously made of glass. Plastic had not been invented yet, so glass was being used. And the reason why they had to be manufactured in a scleral shape was due simply to one feature, and that was the weight of the glass. It was just simply too great to support a corneal contact lens. So the man that is given credit for the introduction of contact lenses to the world is this Adolf Eugene Fick. Now, from 1887 to the kind of late 1930s, all contact lenses were manufactured, believe it or not, of glass. And it wasn't until after World War II that plastics got introduced into the marketplace. Now, the plastics were obviously PMMA, and they had that one primary feature that was very desirable, and that was its durability and its weight compared to glass. It was significantly lighter and much easier to manufacture, so it had some definite positive characteristics. However, as we all know, it had about the same permeability as glass, practically zero. So this continued to be a problem for the contact lens industry until the year 1945. Something happened in 1945 that was pretty exciting, and that was the advent of the first corneal contact lens in the world. And that was from an optometrist in Zanesville, Ohio, of all places. His name is Dennis England. And here is how he manufactured his first PMMA corneal contact lenses. He would take a scleral lens that had been molded to the shape of the eye, and with these two tools, he would either cut a lens in a 7.8 millimeter diameter or in a larger 11 millimeter diameter. These are his original tools that we have in the museum, and that lens that you see on the right is one of the first corneal contact lenses ever manufactured. So, kind of exciting to have that in our museum. Now, why the rebirth of scleral contact lenses? We began our research with the smart lens back in 2008. And there was a lot of preliminary work that needed to take place before the actual design was figured out. Now, three things sort of came together simultaneously to sort of create this new rebirth or renaissance in scleral contact lenses. Number one was we learned very quickly when we started manufacturing these early modern scleral lenses that they were unbelievably comfortable. And it took us a while to figure out why are these lenses so comfortable. And the primary advantage of them is the same advantage we have with soft lenses, not the material. Soft lenses are not comfortable because they're soft. Because if you manufactured a 9.5 millimeter soft lens and put it on your eye, you could not wear that lens. It would be totally unwearable. It would be the most uncomfortable thing you'd ever had, and yet it's a soft lens material. What makes a soft lens comfortable is its lack of movement. Because these lenses don't move significantly on the eye, they're quite comfortable. Well, we learned very quickly that if we place a scleral lens on a patient and if it doesn't move excessively on the eye, the lenses are incredibly comfortable. They are designed to vault over the corneal nerve fibers in both the central cornea, peripheral cornea, and limbus, and therefore they create a surprisingly comfortable lens. The second innovation that was critical to the success of these scleral lenses was the fact that we now had high decay lens materials that allowed the lenses to be worn throughout the day without any adverse edema effects. And here you can see a list of the modern high decay scleral lenses, all of them very, very good materials, and all of them with decays of 100 or greater. So that was a key ingredient to making modern scleral lenses viable today. Now, believe it or not, the third ingredient may have been just as important as oxygen permeability, and that is we, for the first time, had a better understanding of the shape of the sclera. You see, historically, when you and I were in school, we were taught that the cornea had a curve to it and the sclera had a curve to it. Well, that's only partially true. That is, when we use modern OCT imaging, we see that the cornea is only curved in the center 10 millimeters. Beyond that 10 millimeter chord, the cornea takes on a shape that is probably best described as a tangent or straight line. And that straight line, believe it or not, goes out to a chord of approximately 20 millimeters. So now we had the understanding that it was going to be best to align the shape of the eye not with a curved surface, but with a straight line, or what we refer to today as a tangent angle. Now, we must remember that in the evolution of scleral contact lenses, most of the scleral lenses used radii of curvature in the periphery, as seen on the slide on the left. Now, that radii drove the edge of the lens, because of its curved surface, into the conjunctival tissue. And we would frequently have the haptic of the lens tightening on the eye. Through our studies at Pacific University, we were able to show that this was going to be best managed with a tangent surface, one that was tangent to the surface of the eye. And with that innovation, there was a revolution in all scleral lens designs. Today, almost all scleral lenses incorporate tangents, straight lines, in the haptic portion of the contact lens to better align the peripheral cornea and the sclera. If we go back to this previous picture here, we could see the 5 or what's actually the 10 millimeter cord on the top of that image, and we see that the peripheral cornea and limbus is going to be best described as that straight line or tangent. So it's important that we understand this scleral shape because the newer lens designs need to incorporate the appropriate geometry to avoid impingement on that sclera or better bulbar conjunctiva. Well, that led us to the evolution of the smart lens design, which incorporated two tangent angles. One designed to clear the peripheral cornea. We had to understand that the curve of the cornea only extends to a chord of about 10 millimeters. And beyond 10 millimeters, it forms essentially a straight line or tangent. And then we needed a second tangent angle to clear the peripheral cornea and limbus. And with those two tangents, we were able to accommodate and adjust, raise and lower the contact lens to allow for customization of the scleral lens design. Now, it's interesting to note that the only part of a scleral contact lens that is actually coming in contact with the bulbar conjunctiva is the scleral landing zone. All the other aspects of the lens, the central vault, the peripheral corneal zone, and limbal lift zone, are all designed to clear that cornea, limbus, and scleral areas. Now, today we have two primary indications for scleral lenses, and I'm going to now spend the rest of the lecture going into how we incorporate these into the practice and how we incorporate these different pathologies into our lens designs. I'm going to start off with the irregular cornea. And here we see a kind of a portfolio of different corneal and soft contact lens designs that have been designed for the irregular cornea. And today, with our students, our optometry students here at Pacific University, we have to instruct them that we are at a crossroads as to deciding with a new patient, do we put that irregular cornea into a corneal contact lens or a scleral contact lens? Now, how do we teach our students to differentiate these? We do it by virtue of this elevation display map. You'll notice here on the left, we have an axial display corneal topography. Now, it's imperative that we remember that the axial display map is a power map. It tells us little or nothing, believe it or not, about the physical shape of the eye. It tells us its dioptric power only. The map on the right is the elevation map. And what it tells us is where that corneal contact lens is going to land on the surface of the cornea. A 9.5 millimeter corneal contact lens is going to land at an approximate chord of about 8 millimeters, as we see there. Now, we could see here in this nearly spherical cornea, that lens is going to land 360 degrees around. There's not going to be any rocking or pivoting or decentration of that contact lens because the lens is physically landing 360 degrees around. You could see our little tiny bit of apical clearance there, and that's going to be an extremely stable contact lens on that patient's eye. Now, let's take a look at the asymmetric eye, or in this case, an eye with keratoconus. Now, if you look at a keratoconic eye with a power display map, the axial display that we see right there, you could see here its power is greatest in the center, and then there's a lot of symmetry along that horizontal meridian. Where the cornea really goes awry is along the vertical meridian. And that is where we will see tremendous differences in the power and ultimately the shape of the eye, mostly along that vertical meridian. So, this is how we train our students. Look at the axial power map, but hit the elevation display, and within 1 second, the map on the right begins to appear. We teach our students that a rigid contact lens is going to land at the area of greatest elevation compared to a sphere, and that is where the red is. Wherever the red is where the lens is going to land. Wherever the blue is where the contact lens is going to lift off the eye. So when we place a corneal contact lens on this eye, we anticipate that it's going to land on the red at about 4 o'clock all the way around to 8 o'clock, but we're going to see a significant amount of edge lift down below where the depression of the cone is taking place. Now, here is the key, and that is the elevation differential. You'll notice on top the cornea is elevated 90 microns compared to a spherical surface. So it's elevated by 90 microns. You'll see here that down below it is depressed away from that surface by 147 microns. So we add those two numbers together and we call that the height differential. The difference in height along that meridian is 237 microns. Now remember this, if the cornea was spherical, the height differential would be identical above and below, or essentially zero. But now we're at 237 microns. So now when we look at our simulated fluorescein pattern of the corneal contact lens, we see, yes indeed, the lens is landing at approximately 3 and 9 o'clock along the horizontal meridian, and there's a rather surprising amount of symmetry along that horizontal meridian. However, when we look at the vertical meridian, oh my, we've got quite a mess taking place there. We've got a tremendous amount of asymmetry between the superior and inferior portions of the cornea. So now, when that lens is placed onto the eye, we see the lens aligning peripherally from 4 o'clock to 8 o'clock, but we definitely see that edge lift down below. And it is that edge lift that is going to create our greatest dilemma for the individual wearing the contact lens. Now, as you and I know, we've all fit hundreds of patients with keratoconus, and we know that with time, in some of these individuals, they adjust to that edge lift. They adjust their blinking patterns, they just adjust their head motions so as not to dislodge the contact lens. And with time, these become unconscious movements to them, but nonetheless, we can see how the elevation display map and the actual fluorescing pattern are almost carbon copies of one another. They emulate one another almost perfectly. So that is why the elevation display map is so important. Now, if you remember though, we had a height differential between the superior and inferior cornea of 237 microns. Through studies that we performed here at Pacific University, we described how when that height differential number exceeds 350 microns, there's going to be so much edge lift down below that the individual is probably not going to tolerate a rigid contact lens well. In this particular study, on 127 eyes of 87 patients fitted with corneal contact lenses, when the height differential was less than 350 microns, such as this example here with 237, when it was less than 350, we had an 88.2% chance of that individual successfully wearing a corneal GP lens. Now, today, what we have to do with our students is we have to have them look at the topography, in this case, the axial display map, and just ask ourselves, is this individual a candidate for a corneal GP lens or a scleral contact lens? So we're going to go to the elevation display map, and the topographer, at least the Medmont topographer, is going to calculate automatically. We don't do anything. It's going to give us this height or elevation differential number. That number in this case is 315. So there's a 315 micron difference. Now you remember, we said anything under 350 microns has a pretty good chance of wearing a corneal contact lens successfully. Now, more recently, we reapproached this study and looked at a number of eyes, in this case 90 eyes, with a variety of different pathologies and used the MedMount software to determine the height differential number. And then we did an evaluation as to whether or not that individual was going to be able to wear successfully a corneal contact lens. Now, here is our data. And you could see here that if the height differential is less than 200 microns, we had a surprisingly high chance of that individual wearing a corneal contact lens. Now, you could see, though, that in the patients that had greater than 400 micron differentials, none of them were going to be able to wear the corneal contact lens successfully. And it's that group between 200 and 400 micron differentials that is of great interest to us, because some of them can wear a corneal contact lens, whereas others just simply could not and needed to be wearing a scleral contact lens. So it's very important today that we do this height differential number. It gives us insights. It tells us whether or not we have a good chance of a corneal GP working, or whether or not we may want to abandon the corneal contact lens and move into a scleral lens design. Now, here's a rather lovely example of a patient with keratoconus. We can see here these height differential numbers very far exceed that 350 micron threshold. And when we place the corneal contact lens on there, boy, we've got some bad things happening with that fluorescein pattern. That is the actual corneal lens on that individual patient. So this is a patient that may not be successful with corneal lenses and may be better served by vaulting the cornea, the limbus, and landing the lens on the sclera. Now, what if you don't have a corneal topographer to get this height differential number? Don't worry, because when you put on your best fitting corneal contact lens and you see a pattern that looks like this, any of these six, you know for sure that the height differentials in that cornea are so significant that you're not going to be able to successfully fit this patient with a corneal contact lens. When you see parts of the lens jettisoning away, when you see other parts of the lens in very close contact with the surface of the eye, you know that height differential number is high. All six of these fluorescein patterns were patients of mine. These were patients I had fitted with corneal contact lenses, and today it is not surprising at all to me that we were unsuccessful with the fits of these lenses. Now, patients may be able to gut through it, is what we call it here, and they may be able to adjust to this rocking and pivoting, but for many of them it disrupts their wearing time rather significantly. So let's now take a look at this patient here with bilateral keratoconus. The keratoconus is worse in the left eye than the right eye. And let's now approach this with a little bit more science than just saying this patient has keratoconus. We're going to look first at the elevation display map we see here on the right. And now we're going to use the elevation display map. Now, I want you to pay attention to this because this was like of extreme kind of interest to me when we saw this patient in the clinic. The patient had relatively small amounts of corneal steepening, K readings of 4337 by 5262. So, relatively small amounts of what we would call clinical keratoconus. But you could see here in the height differential, this patient had a 703 micron difference in height between the superior cornea and the inferior cornea. Now, that is going to create a significant amount of edge lift down below, making this an unsuccessful rigid lens modality. Now, it doesn't matter whether you're using spherical GPs or aspheric, symmetrically aspheric GP lenses, that edge lift is going to be an issue for the patient. So now we tell the student that this is probably going to be a candidate because of that height differential that is going to be better served with a scleral lens. So we have the student measure the visible iris diameter, and then we add this important number to it, 3.5. And that provides us with a very important number. It tells us the smallest. Now, I must reiterate that. This formula tells us the smallest scleral lens we're going to be able to place on this individual and create the peripheral corneal clearance and limbal clearance that are important in a scleral lens design. So this 11.8 millimeter cornea, the smallest lens diameter would be 15.3. So this is why we selected that 16.5 diameter as one of our primary diameters for sclerals. Now, as you know, we're going to go to our diagnostic set and put on a base curve, a sagittal height, I should say, of 4,400 microns. The elevation that is quite frequently used with mild to moderate keratoconus. Now remember, this patient's K readings were surprisingly minimal. You'll see here that they were 4337 by 5262. And when we put on that seg, we saw a significant amount of central apical touch. Now we know that we want to be able to clear the cornea, create no touch, but then in addition to that, we also need a sagittal depth that's going to provide us with 300 microns of apical clearance. So it is here that we went into the 5,000 deep lens. It was the lens that created the 300 microns of clearance, and you could see a big difference between those two lenses there with OCT imaging. Now, the same thing is true with pellucid because here, once again, the difference in height between the superior and inferior cornea is going to create some significant issues for us. And here, the primary adjustment we frequently have to make is in the area of that peripheral corneal zone and the limbal clearance zone. We need to very frequently raise that up across the superior portion of the cornea. If you look at our diagnostic lens, you could see that area fluorescein thinning at that 11 to 12 o'clock portion of the eye. And by lifting those angles up, it works just like a drawbridge. It allows us to clear now those areas of the peripheral cornea and limbal areas. So this is one of the features I enjoy so much about the Smart Lens is the ability to make those adjustments. Now, here is something that we adjust with some frequency. We place on a scleral contact lens, and on initial evaluation, we see some fluorescein thinning. But now, after 4 hours of wearing that lens, you could see the impingement of the lens, the lack of clearance in the area of the peripheral cornea. You could see here on the sclera, we do have a tiny bit of limbal clearance, but this peripheral corneal zone is of great concern to us. So here again, we're going to have to lift those angles up to clear that very steep peripheral cornea that this individual patient has. We had a hint of it when we put on the initial contact lens, but after the lens settled in, it really began to manifest itself. We do have to remember at all times that scleral lenses are unique. They are the only contact lens that virtually settles into the bulbar conjunctiva and on average drops about 127 microns. That's at least with our studies at Pacific. Now, the reason that tissue is so compressive is because of the goblet cells that are located in the bulbar conjunctiva. These are rather enormous sebaceous secreting glands that are easily compressed by the weight and pressure and suction of a scleral contact lens. So we have to anticipate that we're going to see about 130 microns of settling. Now, that's going to vary from one patient to the next, but this is an average number. We're going to lose about 130 microns of whatever apical clearance we see at the initial application of the lens. Now, if we forego that peripheral clearance, if we just not pay attention to it, this is what happens to the peripheral cornea. It begins to break down very quickly under the pressure and suction of the scleral contact lens. So we have to make sure on our initial evaluation that we are clearing the central cornea, the peripheral cornea, and the limbus. All three of those need to demonstrate with the diagnostic lens that they are clearing the cornea. If not, those modifications need to be made to the angle. Now, let's change gears a little bit, and now let's go into the pathologic cornea. That is, it's that cornea that is suffering from severe ocular surface disease. And here the list is rather enormous, of the conditions that can be very much served well with the scleral contact lens. What we see here is the fact that when a scleral lens is placed onto the eye, the edge of the contact lens embeds itself ever so slightly into the bulbar conjunctiva and surprisingly creates a watertight seal 360 degrees around. Now, we were very curious a number of years ago how much fluid gets exchanged beneath a scleral contact lens. So, what we did is we took a series of scleral lenses, we filled the back up with a very precisely measured amount of fluorescein, and just simply placed them on our students' eyes. We had them wear the contact lenses with the fluorescein underneath there for 8 hours to see how much of the fluorescein dissipated with that 8 hour wearing schedule. Well, here is the results on our subjects. They all had a similar finding, and that is after 8 hours, that fluorescein was still very much present beneath the scleral contact lens. We had a thinning of the fluorescein, but the intensity of the fluorescein was still very much visible after 8 hours of lens wear, indicating that when a scleral lens is placed on the eye, it virtually creates a watertight seal. Water isn't coming in and it's not going out. Now, I know everyone's in a panic because everyone is thinking, what about metabolic debris and all these other things? Well, we must remember that when we put a patient into a soft contact lens, every time the patient blinks, there is less than 1% tear exchange. That means that greater than 99% of the volume of tear beneath a soft contact lens remains there when a patient blinks. So there's very little tear exchange beneath a soft lens, and probably less even with a scleral contact lens. Well, we took the experiment one step further, and we had individuals fitted with scleral lenses on both eyes. On one eye, we had them use a fluorescein drop every 20 minutes for 8 hours, a total of 23 drops, just to see if fluorescein could find its way beneath the scleral contact lens. Well, lo and behold, after 8 hours, there was no fluorescein present underneath those scleral lenses, and that's after 23 drops of fluorescein being placed into the eye. So this was imperative for us. It told us that these scleral lenses are incredibly unique. They create a watertight seal, which is why they perform so well with the dry eye patient. Here we see an individual with filamentary keratitis, extremely painful dry eye, chronic dry eye condition. We're going to fit this patient with a scleral contact lens, anticipating that their corneal curvature is normal since they don't have any underlying corneal pathology besides the dryness of the cornea. We fill the diagnostic lens up with preservative-free saline. We add the fluorescein. We apply the contact lens. And of course, we look for our 3 to 400 microns of apical clearance. Now, this brings up a very important question. What saline are we going to prescribe for our dry eye or even our keratoconus patients? because there are two different formulations of fluorescein in the marketplace. What we have on top is called Adipac, and that is the one that is used by medical practitioners. It is a hospital grade saline solution. It is a wonderful, wonderful saline solution. But you'll also notice that there have been a number of other salines that have been used with scleral lenses, and what these solutions do different is they adjust the pH. And what do we mean by that? When we look at the hospital grade saline solutions that are just simple saline, sterile saline, preservative free solutions, they have a relatively low pH of 5.3. Now remember, the human ocular surface has a pH of around 7.0. Now you could see here that some of these saline solutions have effectively adjusted their pH to get to a more normal state. Now remember, this becomes important because whatever solution you put in the back of that scleral lens is going to be there 8 hours later. It's not going to drain out. It's not going to leave the eye in any way. It's going to create that watertight seal and hold this saline in place. So our choice of salines becomes important. Now we did now please understand, this was a small study of 6 dry eye subjects that we wanted to test the buffered saline and the hospital grade non buffered saline. We had them fill out a dry eye questionnaire, and you could see here at baseline we had a score of 41.6. So without any scleral lenses, their eyes were very, very dry and very uncomfortable. Now, when we place them in the buffered and non-buffered saline, oh my, there was a big improvement with both the saline solutions. The buffered saline solution, the dry eye score went down to 23.7. Anything less than 30 is completely non-dry eye. And you could see here with the non-buffered saline solution, that hospital grade saline, 27.7. Now, the key here was the forced choice preference. That is, 5 out of the 6 dry eye subjects preferred the buffered saline with their dry eye. So 5 out of the 6 said, oh, this is better. It feels better on my eye. One subject had no preference. They liked both the saline solutions. So this gave us insights into the fact that a buffered saline solution may be preferred. Right now we have a larger study going on beyond this initial pilot, and I think we're going to get some really even more powerful data from that study. Well, now let's look at our patient here. It's a 47-year-old with filamentary keratitis. We are going to put them into the scleral lens, and I want you to look at that same eye 2 weeks later. Following the removal of the scleral lens and the photography, you could see here, oh my, that is quite an improvement. Same thing with this patient with Stevens-Johnson syndrome, an entering visual acuity of 2400. This patient had been on maximum dry eye therapy and was about to lose this eye due to perforations. and we place the patient into a scleral lens. 6 months later, this patient's visual acuity is 20/25. The only therapy this patient was on at the time was the preservative-free saline solution in the bowl of the contact lens. It shows you how powerful hydrating the corneal surface is. Not only hydrating the cornea, but hydrating the limbal area where the limbal stem cells are present. Here's a patient with pretty severe ocular pemphigoid, and you can see following the wearing of the scleral lens, this is about a year and a half later, we see a dramatic improvement in this individual's corneal appearance. Now, it is important that I reiterate that when these lenses settle into the bulbar conjunctiva, that solution remains underneath there. It is imperative on our dry eye patients that we clear the central cornea, the peripheral cornea, and I believe the most important is the limbal area. We need, with white light, to be able to see the fluorescein bleeding across the limbal area onto the sclera, illustrating to us that we have created that limbal clearance. Remember, this is where the stem cells are populated, and those stem cells are such an integral part of the rehabilitation of these dry eye patients. Here's another patient with keratoconjunctivitis sicca, secondary to Sjogren's, and this is that same patient following the wearing of their scleral contact lens. You could see that nothing short of a miracle takes place beneath these scleral contact lenses. So for us today, there is no doubt that dry eye therapies have failed for many of our dry eye patients, especially those with pathologic dry eyes. They therefore become prime time candidates for these scleral lenses. Here's a patient with rather severe limbal stem cell disease, and you could see how much the peripheral cornea has been damaged by the loss of these stem cells. Following the wearing of the scleral lens, look at the improvement. It is just unbelievable. It's case after case after case, illustrating how much these improved not just the corneal surface or ocular surface, but how much they ultimately improve the individual's visual acuity. Very quickly here, I want to share with you one more case report. This is an individual that had keratoconus and had a stromal ring implanted. Pretty easy to see the presence of that intrastromal ring. And you could see how the dry eye had really compromised her ability to wear her corneal contact lens. We refitted the patient with a scleral lens. This is the SMARTLENS design, and you could see here after 1 week a rather dramatic improvement in her subjective symptoms, in her visual acuity, and how excited she was to have her keratoconus and dry eye managed with one contact lens. Now, as you know, these lenses come in a haptic, toric, haptic configuration, and that was all based on data we performed here at Pacific University using profilometry to give us insights into how much toricity is present in the human eye in the area of the sclera. And what we found was that the average was about a 1.5 diopters of toricity, and a differential, horizontal versus vertical, of 150 microns, and therefore the lenses come with a small amount of toricity already incorporated so as to better line with the shape of the normal sclera. Now, here's an individual, and I just want to tell you a little bit. This is a patient who is just one of our study patients, wears daily disposable soft contact lenses, and their cornea is perfectly spherical. Now, look at what happens though in the area of the sclera. The lens lines up along the 180 meridian. I'm going to reach in with my finger and I'm going to malalign that to the 90-degree meridian and just have the patient blink. Now you'll see here the lens is deciding which way to go, and it finally makes its decision, and you're going to see it now dial itself in on this individual patient's scleral toricity. And it will ultimately go back to that 180-degree meridian 100% of the time, and this becomes a lovely way of orienting the optics of the lenses if additional astigmatism is required. Now, here's another patient, but this one has against the rule scleral toricity at 12 and 6. So once again, I'm going to malalign the contact lens and just let it go. Now, once again, it's trying to figure out which direction it's going to go, and now you're going to see it slowly spin itself back to that original 12 and 6 o'clock position. So this is really critical that we understand that almost all human corneas have some degree of scleral toricity, and a little caveat, the scleral toricity is completely independent from the corneal toricity. That is, this patient that we're looking at here had with the rule corneal toricity, but against the rule scleral toricity. So there is no correlation between corneal and scleral toricity. Now, quadrant specific lens designs are available. However, I don't believe they are going to have a strong place in clinical practice until the day we have commercially viable scleral mapping techniques. Now, this is an instrument that is known as the SMAP 3D. It is one of our profilometers manufactured here in the US, and it gives us the scleral shape. With that data, we are able to determine the position of that scleral toricity and the amount of it. And that is when these quadrant specific lens designs are going to very much come into vogue. Well, ladies and gentlemen, that's our story. As you could see, we're a little bit excited about scleral contact lenses and what they mean to us here at the university. I want to tell you, though, that our primary lens is still the corneal contact lens. And many of our patients that can accommodate the wearing of those lenses, that's going to be our initial lens of choice. And it's when those lenses fail that we then move the patient into the scleral contact lens design. So, with that, I'm going to turn the program back over to Ricardo, and we're going to carry on.
Yeah, hi. That was an exciting lecture. I just refresh a lot of things and just learn a lot of things as well. So thank you for that, Pat. Uh, that is wonderful. So now we're gonna move on with Dr. Damati from Damati Optics, and he's a consultant for us at the Middle East region for Spectrum International. So, Dr. Damati, please go ahead. Pat,
Yeah,
Dr. Damati is gonna share screen.
good evening.
Help us.
Yeah, good evening, everybody. And it is a pleasure meeting you all tonight with Dr. Patrick and Dr. Ricardo as well. So I would like to share my case report. I really conducted, and yeah, this one.
Yes, go ahead.
Um, Thank you, Dr. Patrick, for this impressive presentation, actually, and it was really informative for us to know more about the technical parts of these scleral lenses and when to use. But before I go forward to my case report, can I have a question? If there is any study with evidence, any relationship between scleral lenses and IOP? Dr. Patrick? Oh, okay. He maybe is not listening. Hello?
Maybe we could ask later.
Yeah, sure, sure.
Mhm.
All right. Now, I would like to present my case report, which was a very impressive case report, as every patient, they really impressed about these lenses. As the eye care professional, we can change patients' life and people's life. So I have met a patient came to my clinic practice. She is 51-year-old female, complaint from unilateral anterior irregularity with a PKP case. And that was last June 2022. She came from a well-known eye care center for possible right eye management with a contact lens to improve her vision and reduce the headache and the glare. So the right eye with a case history with a BKB management for the past 12 years with visual acuity for 0.1. So she lived with 12 years ago with only visual acuity zero point 0.1 on the right eye. So she was very dependent on the left eye, which she has only simple myopia with minus 0.75, and she was managed with glasses. Actually, the patients were feeling unhappy with her right eye life. So when she came to my clinic, the patient wasn't having this much expectations, and she was wondering how we can manage her eyes after she passed and visits to many eye care centers and having no hope to improve her right eye with better vision. So I asked her directly, let us go in the clinic and try to do the proper sessions to understand your case. She says as a compliment, okay, let's try. So the first step, I asked the patients to do the session and understand her eye care condition with my devices as slit lamp I have and retinoscope. Was looking for objectively to directly to her cornea on the right eye, and I found a clear cornea. And so there is no opacities, so there is right reflect with the retinoscope, so we can do something promising. So I try now. I opened actually my trial set. I have my own trial set from scleral lens with the smart scleral lens design, and I found 15.5 with a SAG of 3, 800 with a base curve 8.04 with the toric edge design, and the trial lens was plano. So the lens, as I put it on her eye, was stable. The patient expressed that's very comfort, and during my slit lamp observations, I'll show you the image, how it was proper aligned on the sclera and away from the cornea, settled after 30 minutes with lifting clearance with central zone with 100 microns. So the mid-prefer was settled also after 30 minutes within 200 microns. The limpal part was approved with an average of 75, almost 75 microns. The landing part was very important also for me to avoid any impingements or aggressive landing. So it was quite flatter than vertically, but it was very aligned and no impingements. So I made certain changes as you expected. So I have to increase the central zone 150 microns more because as Dr. Patrick, we don't want to have any mechanical complications after 2 or 3 hours more settle down the lens that can be very close to the central area of the cornea. Now, here we can see the corneal transplants with the fluorescein, and it was all covered with the fluorescein properly. Now, here the ideal fitting as we achieved after the proper adjustment in this figure. Step 3, after I made an over refraction with the patient as the lens was plano and the trial lens was -5 and the final lens figure -4.75. The visual improved actually up to zero point 0.9 plus. The patient wasn't believe that she was having this much success in vision and comfort. So we agreed to order the lens and she was waiting the lens eagerly to receive it and to use it. So the final parameter of the lens was with a SAG of 3800 with a base curve with a diameter 15.5 with a directoric edge design, and the total power was -4.75. The impressive part of this lens design with the DQB that you have a flatter base curve, so you don't have to be worried that you will be having a very high minus lens. Like I tried other lenses with a DQB and it was expected to have -10, -15, -12. So with these lenses, you can expect lower refractive power and minus, so you can have better oxygen fluxing to the cornea. That's and the lens material I selected for her as an optimum option to have better oxygen, good oxygen fluxing to the cornea and be away from unexpected any mechanical complications like hypoxia and having good surface. During the session's moments, I really exceeded patients' expectation. As many other patients' expectations, we changed their patient's life. And she expressed that she really lost from her life, her vision eye, the right eye for past 12 years. And now the patient was very happy and really she's very thankful person for what she has received from our clinic practice. And the third cycle of this lens, we have to provide the patient enough share time to educate, train them how to use these lenses, because if we miss any of these part cycles to provide these lenses for needed patients for these lenses, we might damage entire practice. So I would advise, please provide enough chair time to train your patients to have final success with your patients. Please give all the information and instructions properly to your patients and keep following them up. And this is my case reports with smart design lenses. Now, any other questions? I'm ready to. Thank you, Ricardo.
Thank you, Nesar. That was wonderful. So happy that your patient is doing well and she's happy to recover vision, which
Yeah,
we,
yeah,
that's what we like, right?
yeah. That's what we like.
That's what
We
we're
like
working for.
working
So
for.
now we will
We
be receiving some questions. We're gonna give 10 minutes to answer questions. So if you would like to uh, place questions, you have the Q&A down below. You have, we will be translating, Dr. Damari will be translating for us.
sure.
So uh, let's see if we have any questions.
Okay.
You, Dr. Nazar, you can ask Patrick right now.
Yeah, Dr. Patrick, it was a pleasure meeting you. It's a good evening from Amman.
Could you say that again? There's a little echo here.
Yeah, I say it was a pleasure meeting you online, and it's a good evening from Amman.
Yeah, okay. Yes,
Yeah,
yes.
yeah.
Very good.
Yeah, I would really appreciate your time with us, providing these informative and presentations with this lens design, which I really started using these lenses 2 years ago, and I found a lot of difference for patient comfort and lens material. But I have a question, two parts of question actually. What about the relationship between the scleral lens and the IOP? And the
The
second part, I would like to discuss the midday fogging actually, and in which material it happens usually.
between the relationship between the scleral and what was that?
The IOP, the intraocular
Okay, the
pressure.
IOP. Yeah, we have been doing a lot of work with that, and we have one of our current PhD students doing her master's thesis or her PhD thesis on that very topic. What we found in our preliminary work was the fact that when a scleral lens is applied to the eye, the intraocular pressure goes up about 5 to 7 millimeters of mercury. So if the IOP without the scleral lens was 20, we anticipate that the IOP would raise about to 25 to 27. Now, the increase in intraocular pressure, however, when the scleral lens is removed, within just seconds, it returns back to its normal shape or normal IOP. So it's only when the individual is wearing the scleral lens that the IOP increases. So this is a little bit of a concern, and we want to pay very close attention to this, especially in our patients who may have glaucoma or borderline glaucoma. And so our research is continuing in this area, and we hope to get some more important information from this PhD project.
Thank you for. But do you think this is a general common for all cases, expected to have increasing 5 to 7?
Okay, I missed that one. I'm sorry.
Yeah, do you think is this evidence studies that reflect that it is a common to increase the IOP 5 to 7? No.
Yeah.
Okay.
Now we had a number of the subjects in our study that their IOP increased even higher than that. So it's going to be something we're going to want to pay attention to. I'm relieved with the idea that the IOP goes back to normal. Once the lens is removed from the eye, it returns back to normal very quickly. But still, there are some things we could possibly do in the design of the contact lens to lessen that suction force. And it's not surprising that these lenses do create a little increase in IOP. And I believe that the majority of that is related to the suction properties of a scleral contact lens. So these are things that we're going to continually monitor and we're going to continually address in our research lab here at Pacific.
Thank you so much. My second question about the midday fogging, and does it have any relationship with the lens material, more commonly with coming with the Contamac or Boston?
Ricardo, could you repeat that for me, please?
Yeah, it is about midday fogging. If it has a
Okay.
relationship with material like Contamac or Boston material.
No, we believe that this midday fogging is not a material phenomena. It has to do mainly with the fit of the contact lens, especially in the area of the haptic. Early on in scleral lenses, when we were using symmetric scleral lenses, we had about a third of our patients have the midday fogging. When we went to the toric haptic and aligned the cornea or the sclera better, the incidence of this midday fogging went dramatically down. So that led us to believe that this is more a relationship, a fitting problem. And we see it when we have some tear exchange underneath the scleral lens, when we don't have enough toricity in the haptic portion of the lens. And when we have that clearance, we get the fogging taking place. So, what we'll do is we'll put the scleral lens on the patient, put in fluorescein, and see where the fluorescein is coming in to the back of the contact lens. Where the fluorescein is coming into the contact lens is where we need to increase the toricity of the haptic. And we found that that dramatically does address the fogging issue.
Great. Thank you so much.
Thank you.
So we have one question for Dr. Nesar. Um, they're asking if you perform any topography before fitting your case.
Yeah, I do. Sometimes I do have topography corneal imaging, and if I don't, I can use my trial set immediately.
And we have another question from Dr. Swarna. Any comparative studies done on IOP changes between smaller diameter versus larger diameter on scleral lenses?
Yeah, in one of our pilot studies, we used two different diameter lenses, the 15 and the 16.5. And we found no difference in the diameter of the contact lens because when that lens lands on the sclera and it settles into that bulbar conjunctiva, it is at that point it creates the watertight seal and then it begins that suction force. So We looked at that. We're going to look at it again. In all of our studies, only one eye is fit with the scleral, the other eye with a silicone hydrogel soft lens. With the eye fitted with the soft lens, we never saw an increase in IOP. It was only with the eye wearing the scleral contact lens that we noticed the increase.
Okay, perfect. So we're gonna answer two more questions. Okay. Okay. Well, actually, it's three because one question has two questions.
Okay.
Yeah. So Dr. Hakim has the following question. Is there a way or an easy way to get an instrument to measure pH in a solution?
Yeah, we just ordered online a pH meter, and there are hospital grade pH meters that are very accurate. So we just put the saline into a sterile bowl. We drop in the probe for the measuring of the pH, and it gives us the pH reading. We do that, 5 times, and take the average of the five, and that's what we report.
Okay, perfect. And the second question from Dr. Hakim is, when treating a pathological case such as SJS, do we feel any medication in the bowl in addition of the saline or just the saline or only medication?
Yeah, that's a great question. Now, we use only saline, and the reason for it is that most of the medications, as you know, are preserved. And the preservatives trapped underneath that, within that bowl, are going to create significant issues. Now, even if it is a preservative free formulation, we still have seen such a therapeutic effect with just the preservative free saline that is really our treatment of choice. And here again, we're starting to lean more in that direction of those pH balanced saline solutions in the back of the scleral lens. So we feel pretty comfortable that that's the way we need to go.
Okay, perfect. So, yeah, this is the last question. So Dr. Luhain, is saying first, thank you for these very valuable lectures. My question is about fitting scleral with very thin cornea and cornea with compromised endothelium. Is there any dangerous of hydrops? Danger of hydrops?
Yes, there sure is.
Yeah.
Let me tell you, when those corneas get very thin, we have to work with the patient very carefully on their removal technique. Because, as you know, with the removal of a scleral lens, there is an element of suction present. And if they pull too much in the center of the contact lens, we really are a bit afraid of inducing a hydrops. So we work very carefully with these thin corneas to make sure we are using the proper removal techniques. The other thing is this compromised endothelium. Our studies here at Pacific have shown that frequently when the cell counts get down to less than 500 cells per square millimeter of the endothelium, the corneas are somewhat prone to getting cloudy due to a lack of oxygen. And that has been a problem for us, even with the ultra high DK lens materials like the Contamec Infinite and others, which have a DK of 160. For some of these patients, it's still not enough with these compromised endotheliums. So we've had to abandon scleral lenses on a few of our patients due to the inability to get enough oxygen through the lens material.
Yeah. Okay. So whatever questions were left, we will send it to Patrick to get his answers, and we will send it by email.
Okay.
We have extended the webinar, and so we're gonna be ending it right now.
Yeah.
Thank you, Patrick, for your
Thank you.
time.
Thank you.
It was wonderful. I really learned a bunch
Okay,
Yeah.
and
good.
refreshed
Yeah.
a bunch as well. So thank you, Dr. Nassar, as well, for your
Thank you
patience.
all.
Thank you,
Uh,
everyone.
it was really wonderful spending this time
Yeah.
with all the audience.
Yes.
We will
And
be
hope to see Patrick this coming GSLS so we can have many further discussions regarding more
Oh, I
study
would love it.
businesses.
Love it.
Yeah,
yeah.
yeah, yeah. It's
Well,
very
come meet.
excited. Yeah,
Thank you.
thank you.
Okay.
Thank you
No,
so much.
thank everyone for listening to Dr. Professor Patrick and Dr. Damari. It's been wonderful. Have a nice night. Patrick, have a nice evening.
Okay, will
Yeah,
do. Thank
Okay.
you.
yeah.
Thank you.
Enjoy.
Bye bye.
Thank you. Bye bye. مها مرحبا، كيف حالك؟ هلا، كيف؟ أحسن من هذيك المرة، صوت أوضح.